Hello and welcome to this presentation on abdominal vasculature. Today we'll explore the anatomy of major blood vessels in the abdomen, including the abdominal aorta and inferior vena cava, along with their branches and tributaries. These vessels are vital for delivering oxygen and nutrients to the digestive organs, kidneys, and lower body, supporting critical physiological functions. We'll examine their normal anatomy, embryonic development, anatomical variations, and clinical significance. Understanding abdominal vasculature is essential for medical professionals, aiding in diagnostic imaging, surgical planning, and managing vascular diseases. Join me to gain insights into this complex and fascinating system. Let's begin with the size, dimensions, and shape of the abdominal vasculature. The abdominal aorta begins at the T12 vertebral level with a diameter of about 2.8 centimeters and tapers as it descends, measuring approximately 1.5 to 2 centimeters below the kidneys. A normal abdominal aortic diameter is less than 3 centimeters. Diameters exceeding this indicate an abdominal aortic aneurysm. The inferior vena cava has a normal diameter of 1.5 to 2.5 centimeters, varying with respiration and volume status. The abdominal aorta spans about 13 centimeters in length from the diaphragm to its bifurcation at the L4 level. Now let's move on to its surface anatomy and landmarks. Surface anatomy landmarks guide abdominal vasculature localization. The umbilicus at L3 to L4 marks where aortic pulsation is palpable left of the midline. The transpyloric plane at L1 indicates the superior mesenteric artery origin. The subcostal plane near L2 approximates renal artery origins. The aortic bifurcation occurs at L4, and the anterior vena cava forms at L5. The celiac trunk arises at T12. These landmarks are vital for clinical examination, imaging, light ultrasounds, and surgical planning, ensuring precise vessel identification. The costal margin further aids in orienting abdominal vascular anatomy for medical procedures. The abdominal aorta lies anterior to the vertebral bodies following the lumbar curvature with peak complexity at L3. The inferior vena cava runs parallel on its right. Posteriorly, the cells, muscles, and the sympathetic trunks border both vessels. Anteriorly, the pancreas, duodenum, and small bowel mesentery cover them. The left renal vein crosses anterior to the aorta between the superior mesenteric artery and bifurcation. Both vessels are retroperineal, with the IVC partly behind the liver and duodenum. These relationships guide surgical approaches, ensuring safe access and minimizing complications like vascular injury during abdominal procedures. The abdominal aorta divides into suprarenal and infrarenal segments. The suprarenal segment from T12 to L1 through L2 gives rise to the celiac trunk, superior mesenteric, and renal arteries. The infrarenal segment from renal arteries to L4 bifurcation provides lumbar and inferior mesenteric branches. Vessel walls have three layers: tunica intima with endothelium, tunica media with smooth muscles and elastic fibers, and tunica adventitia with connective tissue. The aorta's media has elastic layers for recoil. The IVC's thinner media and thicker adventitia contain smooth muscle fibers. The IVC includes infrarenal, suprarenal, and intrahepatic segments, guiding imaging and surgical approaches. Having explored the aorta and IVC segments and layers, we now examine their supporting structures. Aortic fascia anchors the aorta to prevertebral tissues. The mesenteric root supports the superior mesenteric artery and lymphatics. The median arcuate ligament crosses the celiac trunk, while diaphragmatic crura encircle the aortic and caval openings. The IVC gains stability from its retroperineal position in liver attachments. Vessel fascia adds further support. These structures ensure vascular stability during breathing and movement, aiding safe surgical mobilization and preventing complications. With supporting structures stabilizing abdominal vessels, we now explore surgical access. The transperineal midline approach offers broad exposure but enters the perineal cavity. A retroperineal left flank incision avoids bowel handling yet limits right-sided access. A midline retroperineal approach balances both, exposing the paravisceral aorta and both iliac vessels. Endovascular methods via femoral arteries enable minimally invasive repairs. The approach depends on procedure, anatomy, surgical history, and surgeon expertise. Precise vascular anatomy knowledge ensures safe exposure minimizing complications during complex abdominal vascular procedures. After exploring surgical access, we examine blood supply and drainage. The abdominal aorta provides unpaired visceral branches, celiac trunk, superior and inferior mesenteric arteries, paired lateral branches, renal, gonadal, and suprarenal arteries, and paired lumbar arteries. The inferior vena cava drains via hepatic, renal, gonadal, and lumbar veins. The portal system drains digestive organs through the liver, then hepatic veins to the IVC. Collateral pathways support flow during occlusion. Understanding these patterns guide interventional procedures and diagnoses of vascular conditions. Beyond blood supply, innervation regulates vessels. The abdominal aorta and the IVC receive autonomic innervation. The aortic nerve plexus from thoracic splanchnic nerves forms celiac, superior, and inferior mesenteric ganglia. Vagal fibers provide parasympathetic input to celiac ganglia. Pain fibers from aneurysms follow sympathetic pathways, causing back pain. The IVC has similar sympathetic innervation. These nerves control vessel tone, blood flow, and pain sensation. Understanding innervation clarifies vascular disease symptoms and informs pain management in surgery and diagnostics. Following innervation, we explore lymphatic drainage. Lymphatics associated with abdominal vasculature follow organized pathways. Aortic lymph nodes, including celiac, superior, and inferior mesenteric groups, drain visceral organs. Lumbar lymph nodes drain kidneys and gonads. These converge at the cisterna chyli at L1 and L2, draining via the thoracic duct to the left subclavian and jugular vein junction. Lymphatics filter tissue fluid, clear debris, and support immune surveillance. Understanding these patterns is vital for staging cancers, tracking metastasis, and planning vascular surgeries to avoid lymphatic complications. After lymphatic drainage, we explore vessel histology. The abdominal aorta's tunica intima has endothelium and basement membrane. Its tunica media, rich in elastic layers and smooth muscle, thins below the renal arteries, increasing infrarenal aneurysm risk. The tunica adventitia includes connective tissue, vasa vasorum, and nerves. The IVC's thinner media lacks robust elastic layers, aiding compliance but risking collapse or thrombosis. These microscopic structures govern vessel strength, flexibility, and disease susceptibility. Histological knowledge enhances understanding of vascular pathology, guiding diagnostic imaging and treatment strategies for conditions like aneurysms and thrombosis. From vessel histology, we explore embryology. The abdominal aorta forms from fused dorsal aortae. Vitelline arteries develop into celiac trunk and mesenteric vessels. Lateral branches become renal and gonadal arteries. The inferior vena cava, or as I call it, the IVC, arises through regression and anastomosis of posterior cardinal, subcardinal, and supracardinal veins. Vasculogenesis begins around day 15 post-conception, with hemangioblasts forming vessel networks. These processes shape abdominal vasculature, explaining variations like accessory renal arteries or double IVC. Understanding embryology aids in diagnosing congenital anomalies and planning interventions for vascular malformations. From embryology, we explore vessel variations. Abdominal vascular variants carry clinical significance. Celiac trunk variations like splenic gastric trunks occur in about 10 to 15% of cases. Hepatic artery variants often replace the right hepatic effect about 20 to 40% of cases. Renal artery variants like accessory arteries occur in about 20 to 30%. More on the left. IVC anomalies include duplication or left-sided position. Portal vein trifurcation is common. These arise from embryological errors in regression or persistence. Recognizing variants ensures safe surgical planning, imaging, and interventional procedures preventing complications. Beyond variants, we explore vessel physiology. The abdominal aorta maintains pressure via elastic recoil and Windkissel effect, smoothing pulsatile flow. Laminar flow triggers endothelial nitric oxide release, supporting vascular health. The IVC's high compliance adapts to venous return changes, varying with respiration and volume. Autoregulation ensures organ perfusion, despite pressure shifts. Endothelial cells regulate tone via nitric oxide, prostacyclin, and endothelin. This physiology allows vascular function, guiding diagnoses and treatment of diseases like aneurysms. Thank you for watching this presentation. I hope you learned something very informative today. Thank you again.